Good morning, good afternoon, everyone. My name is Gabriel Catan. I'm a Health Tech Ninja and Health Innovation Associate at the IDB Lab. Thanks everyone for joining and welcome to our event, Doctors and AI, How is Medical Imaging Benefiting from AI in Latin America and the Caribbean? Perspectives from the public and entrepreneurial sectors. This is the first joint webinar of the series Transforming Health in Latin America and the Caribbean through Innovation, jointly organized by the IDB, IDB Lab, and IDB Invest. The event will be mostly in English with Spanish interpretation. Para escuchar el evento en español, haga clic en el icono del mundo que encontrará en la parte baja de su pantalla y seleccione la opción de español. We will also have available the questions and answers Q&A functionality at the bottom of your screen, so you can post your comments and questions. By the end of the panel, we'll be selecting 2 or 3 questions to be asked to the panelists. To start, we'll have some opening remarks by Irene Arias, CEO of IDB Lab, followed by Pablo Ibarran, Chief of the Social Protection and Health Division of the Inter-American Development Bank. Irene, over to you.
Thank you very much, Gabriel, and good morning, everyone. Thank you so much for being here. It's great to welcome you to this first webinar of this series, Transforming Health in LAC through Innovation. I want to, first of all, thank all the colleagues, Gabriel and Pablo's colleagues who've worked jointly with us to organize this, and to also thank the speakers that are joining us today for their time, and I think for what they are about to share in terms of putting together different perspectives of their experience and how we can together foster innovation to tackle the persistent health system challenge in Latin America and the Caribbean. For those who don't know IDB Lab is the innovation lab and the venture capital arm of the Inter-American Development Bank. IDB, of course, being the leading source of development finance and expertise for improving lives in Latin America and the Caribbean. And IDB Lab's role and how we complement our the other 2 entities of the group, IDB and IDB Invest, is by driving innovation for inclusion in the region. And we do that with financing, with knowledge, and with connections that go directly to innovative entrepreneurs like Anthony from NeuralNet, who's here, and all to have the biggest benefit we can to improve lives of poor and vulnerable population in the region. IDB Lab has done this now for 30 years. It's our 30-year anniversary. We've approved over $2 billion worth of different projects in all of the 26 countries in Latin America and the Caribbean. And we want to go much deeper in projects that are tackling the health gap in the region. And it's one of our 5 verticals. And we've already deployed about $30 million in early stage ventures that are moving the needle in how the sector can improve access and quality of access to particularly poor and vulnerable population. But we want to do much more with startups, with venture capital funds, and with other entities in the ecosystem that can help us improve in areas like aging, service delivery, non-communicable diseases, telemedicine, AI applied to all of these, and that it can also be done in a responsible way to improve health equality and also women's health. The opportunity is massive. I think we see that according to the IDB, a digital health market in Latin America and the Caribbean will reach $20 billion by 2024. So we want to find the most viable and innovative business models that can tackle this market. According to Bloomberg, the LAC health tech companies increased their financing by 44 4,700%. Obviously, there was a very low base, but we see that this market is growing very, very fast. And watching these trends, starting with telemedicine, remote monitoring, and health insurance at lower prices, better quality for people who did not have access before, and including in such important topics like mental health, aging, and non-communicable diseases, will be something that we can do a lot more, and we're ready to support those innovations. So this series will help us share insights, will help us foster public-private alliances that can help us ensure that those innovations are actually scalable. So thank you so much. I'm really looking forward to listening to all of you, and thank you again for being here. And over to you, Pablo.
Thank you very much, Irene. And I'm very, very excited about this partnership that shows the strength of the IDB Group, bringing together the Innovation Lab with our work in the public sector, where scale and coverage of vulnerable population really takes place. At the Social Protection and Health Division, we work with the countries to support a more productive and equitable region. And right now, we're focusing on the digital transformation of the health sector to improve coverage, quality, and equity in services. It is important also to mention that since 2018, the IDB has partnered with the Pan American Health Organization, that's the regional office of the World Health Organization, to work together towards the digital transformation of health in Latin America and the Caribbean. Together, we have the mission of supporting and enhancing this transformation that is driven by countries. I would like to share with you a brief consideration about the importance of digital transformation and artificial intelligence, together with working in conjunction with several actors, and how this is already transforming the digital health reality in the region. At the beginning of the pandemic, between March and July of 2020, almost half of the population in 18 countries of the region did not receive the care they needed. On the other hand, it is estimated that 60% of the cost of public health services in the region is to pay for personnel. However, shortage and an uneven distribution in all levels of health personnel in the region limits the effective implementation of any existing health plan, and also limits the efficient use of health infrastructure and facilities. And here is where digital transformation is very relevant, as it can improve both the quality and the efficiency of health services in several ways. It offers the opportunity to harness the transformative power of technology to address fundamental failures and evolve the region's healthcare systems into a new reality. When done correctly, artificial intelligence, which in this setting is the ability of software or machines to do some tasks that a human would usually do, this presents a unique opportunity to facilitate and enhance the work of health professionals by expanding their coverage and the quality of their services. It has the potential to improve individual and public health by improving access, clinical decision-making, and creating new efficiencies in clinical care and research. But artificial intelligence by its own is not enough. Public-private partnerships are an essential vehicle to meet the needs and support of the health services. In fact, to be able to really transform a region, we need to create an ecosystem, a digital health ecosystem, with all actors, public, private, academic, startups, and citizens joining together. Real transformation is only possible if done through this ecosystem. And let me share a very nice project that has already been delivering results. And this is a project, a fair LAC in Jalisco, in Mexico. It's a joint initiative led by the IDB Group with the participation of the university called Tecnológico de Monterrey in Guadalajara, the government, the state government of Jalisco, and C-Mind. So you can see here all actors working together. And this is an applied research project that is focused on the early detection and timely treatment of diabetic retinopathy through the use of telemedicine and artificial intelligence models. This project allows for the early detection of this condition at levels of care where it was not possible to do it before. This allows to refer a patient in a timely manner to a specialist to prevent the visual loss and blindness caused by this condition. In this condition, visual loss is preventable if detected early. So through this project, we have already treated more than 1,000 diabetic patients in 3 health centers in Guadalajara. And more of 150 of these patients has been identified by AI as being suspects of having vision-threatening diabetic retinopathy and have been referred to specialists. So this is a very concrete example that shows how lives can be improved by the use of artificial intelligence and working in this ecosystem. Guaranteeing good health for us is possible in Latin America. And why I want to be very emphatic about this. We need a digital health ecosystem to do this. Usually, the absence of a comprehensive strategy and sustained commitment from those leading the digital transformation has been a challenge. But today there's an agreement that of the importance of the digital transformation of the health sector at a global level, almost unanimous. And this has been signed by the highest political level in countries and regional organizations. It is now up to us and to the region to decide how and if we will continue to adapt and make progress. Thank you very much.
Thank you so much, both Irene and Pablo, for your opening remarks. The need for more human resources in health service delivery is a big challenge in Latin America and the Caribbean, as Pablo was marking about. Radiology has been affected considerably by COVID-19 due to the need to extensively analyze a large amount of chest X-rays to detect pulmonary problems. In previous years, several initiatives worldwide have developed algorithms that could support radiologists in triaging and analyzing complex images, sometimes difficult to the human eye to discover any abnormality. According to Business Wire, the global medical imaging and AI market will reach approximately $8.2 billion by 2030 at the compound annual growth rate of 34.7%. According to a definition of Global Lens Wired, AI, or artificial intelligence in medical imaging, indicates the application of artificial intelligence techniques such as machine learning and deep learning to the field of medical imaging. To analyze medical images and assist in diagnosis and healthcare professionals in making informed decisions, it includes the use of computer algorithms and models. AI in medical imaging goals is to enhance this process by leveraging computational techniques. As organizations are collecting more and more data every day, systems that can facilitate the triage and decision-making process could not also reduce the burden on physicians, but also provide more quality and insights to the analysis and increase accuracy of diagnostics. I'm pleased to welcome our panelists of today. Through our conversation, you will learn how both the public and private sectors are embracing the challenges associated with the radiology practice and how AI is supporting it. You will also learn about the interaction between the human and AI and the ethical challenges it may pose. To present the vision of the public sector and from a radiologist point of view, we have with us today Dr. Esteban Hevel, a seasoned Chilean biomedical informatician and diagnostic radiologist with more than 15-year track record dedicated to healthcare information systems and currently senior interoperability advisor at the Chilean Ministry of Health. In order to see how the private sector is designing and providing solutions, we also invited Anthony Iger, CEO of NeuralMed in Brazil, a company that is being supported by a direct equity investment product of IDB Lab. So welcome both, and thank you so much for your time. I know, Esteban, you need to catch a plane very soon, but thank you so much again for your time. So to start, if you're okay, we are going to start with Esteban. As a radiologist, and interoperability advisor in Chile, what do you think are the key challenges radiologists are facing and that AI could help to overcome?
Thank you, Gabriel, for the introduction, and thank you for the invitation again to this wonderful session. Probably from the public health sector, the biggest difficulty that we face is the lack of workforce necessary to interpret the large amount of information that comes out of these wonderful pieces of machinery that we have for diagnostic radiology. The level of precision and the amount of information that is acquired from the human body in such short periods of time, it's enormous. So we, at the moment, in terms of throughput inside of a radiology department, we have our biggest bottlenecks are moving the patient in and out of the room where the examination is taking place. So the sheer acquisition of the exam, of the test, of the images is nowadays the shortest part of the entire process, extracting the magnetic resonance, which has its own physical limitations in order to shorten its period of time, its times. And we could go further into the advances in artificial intelligence in that realm. But nowadays, in terms of the amount of information that is available from our patients and the lack of the available workforce appropriately trained to interpret that imaging is probably one of our largest difficulties at the moment. So our workforce is highly constrained in terms of time and pressure, and that comes with a cost on both efficiency and quality, right? So from the public health sector, from the area that has been historically has had less workforce available, being less able to recruit seasoned senior diagnostic radiologists, the amount of information now available in terms of the time required to interpret appropriately with the desired quality is one of the key aspects where artificial intelligence might have a specific role and a help, would be a significant help for us in the sector. So I see many, as an interoperability expert, I see many other difficulties in terms of workflow integration. So how do we bring into the radiologist room, right? So the report room, these technologies in terms of being able to be a benefit directly to the reporting process. So, but we can go further into that topic. I think that there are many instances, there are many possibilities to incorporate another thinking machine, right, into the exam room and into the reporting room in the future.
Thank you so much, Esteban. So, Anthony, you are as a CEO of NeuralMed. Tell us a little more about NeuralMed and how you are tackling those challenges that Esteban was mentioning. Maybe can you share some insights into the current landscape of AI implementation in Brazil, medical imaging in Brazil, and how NeuralMed is contributing to this transformation? Over to you, Anthony.
Perfect. Thank you. First, thank you very much for the invitation to participate. Obviously, we've been doing this since 2018, so we're very happy when there are more events that we can talk about real use cases and how it actually improves lives, and not just AI is not just something that you read as a headline, because right now everyone's talking about AI. It's something that really exists and is helping patients and doctors and workforces in general everywhere. So NeuralMed started in 2018, as I said, focused on radiology, helping the workflow, exactly as Esteban was saying, helping the decision-making process, especially where we have in Brazil, probably especially comparing even to Latin America, Brazil has one of the lowest doctor per population ratios, especially if you leave São Paulo and Rio de Janeiro, the highly dense and more the richer cities of the country. So we have very specific issues, such as chest x-rays being performed in emergency rooms and the decision being made by a general physician, not necessarily a radiologist. So you need to improve decision-making process time, obviously, because emergency rooms, you need to go through patients quickly because there's always a large line, especially when you're talking about large public hospitals in Brazil. And also in improving the accuracy, because sometimes you don't have the specialist that you need. So that's where we started. As we grew, we improved into not only just imaging, we understood that we needed to look at the patient as a whole. So we look at all of medical imaging in radiology, a little bit in cardio as well, when we're talking about EKGs. And then we also look at the tech side. So all the reports that the radiologist writes, you need to take action on that. So we say that our radiology solutions are the best solutions for non-radiologists because we're working before and after the radiologists. Radiologists are amazing professionals. We just need to improve their work, the time that they need. They don't need to spend so much time looking for data and writing data and then looking for the patient after they've made a decision. So that's where we work on both sides. And then as we improved in the last couple of years, we improved our NLP solutions, our natural language processing solutions, to look at any kind of free-form text in all of healthcare. Especially actually echoing a little bit of what Pablo said, we have a lot of work in Brazil looking for chronic patients, specifically diabetes, which happens to be the mother of all chronic patients. And we've been very efficient in finding these patients by mining and refining all this data that's been there. As far as the second part of your question, Gabriel, as far as what we've been doing and how we've been affecting this, Brazil, I think post-pandemic has understood that we need quickly to use technology to be able to treat our patients in the correct manner that every physician, every nurse, every medical staff expects to. So the adoption of AI and technology in the last 2 years has been astronomically higher than 3 years before this, as far as like the 5 to 6 year window that we've been seeing, especially when you're able to position yourselves as an aid. No AI solution, especially not ours, wants to substitute a doctor. We want to make sure the doctor, the nurse, whoever is taking care of the patient, can spend 90% of their time taking care of the patient and not 90% of their time looking for data, trying to understand in which system the document is, or waiting for interoperability to happen. So that's kind of what we believe in, and that's been helping us grow. So if you look at the last 12 months, we've implemented over 100 hospitals in all of Brazil, from north to south, because of this, not only of our technology, but also because Brazil is looking a little bit with brighter eyes to using AI as a tool and not a substitute.
Thank you so much, Anthony. And you made that point about adoption that we are going to talk about in a bit. But before that, can you tell us a little more about some results or impacts that the solution has been having? Do you have some success stories or use case that you would like to share with the audience? And I would like to remind the audience that you have the possibility to put your comments or questions on the QA chat. So later on the call, on the webinar, we could pick some questions and ask to our panelists. So over to you again, Anthony.
Perfect. So as I said, there's an evolution to patients, right, as they move into the system. So I'll give you 3 results that we've had that are very interesting as the patient moves in. So our first solutions that we use in emergency rooms, because we're able to separate critical patients from less critical patients and help the nursing team organize these patients and make sure this patient needs to go quickly to a doctor, this patient can wait a little bit longer because of depending on what the critical level of the image is. We've been able to see an increase in a decrease in about 9% of patient time, waiting time in emergency rooms. I know 9% seems like when we're talking about these astronomical hundreds of 500 times more investment, as Irene mentioned, but 9% in the emergency room is brutal. It means that each patient can save time. So you think in a hospital in Brazil, in a public hospital, some people wait up to 2 hours. If you're able to take away 9% of this time, of the waiting time, you add this into a day, you're able to treat more people in the same day with the same structure, which is very, very important in Brazil, where the structure and the team is a bottleneck. As you move into teleradiology, which is when you're not in the emergency room, where you're looking in reading rooms outside of the emergency room, the hospital system, we do the same thing. We separate these images into critical and non-critical. And then we've seen drastic changes by being able to organize these work lists, the work list that the doctor needs to look at, as saying, look, this work list is more normal. This work list has more critical patients. Not only you're able to send the critical patients to those very, very highly specific and very expensive doctors, which are less frequent. You're very high, they're rare animals, right? These very, very special doctors, but the population on the most part is healthier. So there's less cases that go to these doctors. So you're able to efficiently use your resources, but most importantly, you're able to decrease time. So one of our first cases, one of our first teleradiology cases, because it's been running for a long time, we've seen up to more than 70% decrease in the time between the exam being performed, the image being captured, and the report being signed off by a doctor in the critical levels, and about 40 to 45% in the least critical. So we're able to organize and make sure the critical patients are moving and being treated quickly. If you move in, and you see my background is pink right now, because right now in Brazil, there's a Women's Health Month awareness. So in the mammogram side, we do the same thing. We're not there to diagnose the patients. That's the radiologist, the mastologist department. What we do is we separate these mammograms into BRAD 0 or 1, which are low risk for cancer, and BRAD 3, 4, or 5, or densities. So these patients that travel 300, 400 kilometers to come to a hospital, they don't go home and then come back. We're able to triage these patients and quickly make sure that these patients are being taken care of now. This is one of our newest technologies that we're implementing in hospitals right now. But alongside with this, one of our clients we've been very happy that they've been reporting their data, and they're telling everyone there's data, so I can tell them as well. They've been using the NLP side. So once the doctor writes the reports, our algorithm is able to read that and automatically send an alert to the requesting physician, say, look, requesting physician, your patient has a high-risk mammogram, please follow up. And that has been able to lower from 30 to 6 days, the interval between doing a mammogram and doing a biopsy for a potential cancer. So we're talking about almost a month or more than 20 days that you're potentially bringing closer a patient to a diagnosis and initiating a cancer treatment, which the doctors in the room can say more than I can about how valuable that is in a potential positive outcome for healthcare.
Thank you so much, Anthony. Those are amazing results. And I'm wondering, I mean, if the results are so great, you know, I was wondering, you mentioned about the adoption of doctors. So I wanted to ask Esteban a couple of questions related to that, right? So how, how healthcare professionals are effectively interacting and collaborating with AI technologies in radiology while still maintaining the quality and accuracy of diagnosis, right? Do you think that they are feeling kind of their jobs are being threatened or jeopardized by these technologies? What do you think about, I mean, what are the adoption challenges from your perspective as a doctor?
Yeah, absolutely. Well, first of all, we are using more or less, yeah, in the industry in general, different types of AI through the entire workflow process. And that's amazing what was just mentioned, right? So we are recognizing patterns in speech with speech recognition in applications that do the triage for a scheduling process, for example, on the scheduling side. Then we can shorten the times of acquisition on a magnetic resonance, for example, doing artificial intelligence. And we're doing computer-aided diagnostics for mammograms, for CT, for MRs, and many others, right? And now also, as was mentioned, with CRs or with chest X-rays, right? And the NLP side on the report building and the analysis and the updates, right, for the patient and the notifications, yeah, the mandatory notifications that need to happen. So we are somehow moving away from the classic FIFO, right? So the first in, first out list of patients, right? So we are being able to move away from a simple time perspective to sort our patients, right? And we can actually get that data that we acquired for your own use, so we can prioritize our patients above one patient above the other according to the severity of their disease, right? I see the actual implementation on general physicians, I think it's more complicated, because still the human brain is an amazing excuse me. The human brain is an amazing machine to build connections between different things. So, and that's how we are trained as radiologists. So the amount of time that we take as a senior radiologist to see the anomaly in the test, it shortens in the time, right? And so general practitioners, mostly in their early stages, will see the benefit of the AI pointing out the anomaly in short periods of time, and even they couldn't have seen it eventually, right? So it will be useful mostly on that early stage of the medical career, which is the most vulnerable to malpractice issues, right? So and you are mostly overworked and tired, and you spend less time actually analyzing what is important or separating what is important from what is not important. So in that sense, AI will be a significant changer on the general practitioner side. So I think that we need to be extremely clear to our practitioners, to our general physicians, that we are doing an artificial intelligence process. We need to be extremely clear what is the type of process that we are doing, what are the biases that it has, in order for them to balance the costs and benefits of that second opinion that they are getting, basically, with this tool, with this computer assisted diagnostic tool. But I think that we have seen since the pandemic, we have seen that the general practitioners tend to rely more on those tools than the radiologists, so their diagnostic aiding tools, because the radiologist gets that information pretty quickly from analyzing the image, and not so much for the general practitioners. And the general practitioner needs to keep the machine moving fairly quickly in order to see the next patient.
Thank you so much. You touched exactly a point that it's actually the topic of my next question. You mentioned the word bias, right? And bias is one of those elements that we consider when we are analyzing AI solutions. Pablo was and Irene were commenting about the LAC initiative as well. That is the framework that we have to support the different investments that we do in AI to review if they use responsible AI, right? And there are no ethical issues. So from your perspective, and maybe also Anthony, after Esteban, you also can mention about how also Neuromed is working on those issues. But what are the ethical aspects, right? What are the key aspects in terms of responsible AI or bias that we can see in algorithms used for AI in radiology?
Well, one of the biggest issues that we have is privacy and security. Yeah, that's the first one, and that's a big issue, right? So although we have a DICOM standard since the 80s, right? Since the mid 80s. So, and it's probably where the anonymization processes are more sophisticated than in any other interoperability standard, right? We still lack a proper. We will always face the issue of privacy and data sharing, right? So this is information that needs to go somewhere else in the world, right? to be processed to come back, right? So we need to move further. So there are certain countries that have very strict regulations on terms of where the information has to be stored and what is the difference between anonymized and de-anonymized or identified information, right? So there are regulating bodies that are fairly old in terms of what we have to do. So the processing machines are not always inside of the same country, and you need to send it somewhere else because you have larger processing capabilities. And yeah, so that's one issue. So we have a problem. We have a pretty big problem with bias. So we have to, and that I'm a biostatistician by training during medical school. So the classic biostatistic methods do not have their own biases, but they do not rely on a training set, right? So the training set, and we have seen it in many other industries, the training set of that AI can determine certain biases of the outcome of the prompt that you're getting as the end result, right? And we need to face that possibility of bias, and we need to know, and we need to start training our algorithms on local population to have it run on less bias, or to be fitted to our own population to get better outcomes. The better the information you feed it, the better the outcome that you will receive afterwards. And we have the natural issue of job displacement. So what is going to happen with the current radiology workforce? So one of the biggest concerns for the radiologists is that laboratories used to have physicians looking through the microscope, right? And the machine has replaced basically all of them, right? So there's almost no analytics done by humans inside of a laboratory. Laboratory is it's a totally different animal, but it's the closest. They are always our neighbors, right? So it's the radiology department, and right next door is it's the laboratory, so the general lab, and they see that with concern. So we've seen entire industries morph during time, even disappear, right? But we know that this is going to move forward. So we are being able to have better quality, higher times, better efficiency, better quality, and there's no regulation that could last forever, limiting the advance of the humankind, right?
Thank you so much, Esteban. Anthony, Esteban mentioned privacy and security, training set, it's connected to the bias of information, and job displacement. So how NeuralMed is working on those issues, or maybe others that you would like to mention?
Perfect. So I'm sure those are the main ones. There's just one more that I would mention, but how do we help, and how do we, I'm not going to say solve, but how do we work towards making the world more comfortable with these issues, which are issues, and they're always going to be issues of, and I think post-pandemic, the world noticed that sharing of medical data can help other people, because you learn with other regions and you're able to do more studies and stuff like that, but it has to be done responsibly, and you have to know how to anonymize data, how to respect current local laws, and all this. When we started, there was no one really doing correct anonymization and following laws, especially if you look at European laws. The Brazilian privacy laws have emulated a lot of the Brazilian, so the Brazilian laws have emulated a lot of the European laws. So what we did was basically, as part of our solution, all our clients get a gateway that we install into their data, into their infrastructure, be it locally or cloud. And it does all the anonymization according to exactly what the local legislation says of what is 100% anonymous data, to make sure that we're able to follow the laws and move that towards clouds, towards be it clouds in Brazil or outside of Brazil, depending on the type of data. And because of this, the most important part, and this moves me towards the point that I don't think was mentioned, which I think is the most important part, is transparency. So this gateway and the way it's done, we give our clients the key. They get this. It's a gift. It's not ours. They see all the anonymization process. They can control this process. And transparency has always been part of our core. We don't believe in AI being a black box that we're going to look at a doctor like Esteban, who has more than 15 years of experience doing this. Like, just trust me, this guy has this. It's not how it works. You have to understand the brain is an amazing thing. So what we do is we triage, we show data, we show why we think certain decision is there. We show the numbers. Like, look, it's 98%. There's no such thing as 100% decision in one way or another, or 0%. We show them, look, there's a 20% chance. But a 20% chance, as a statistician would say, is a 20% chance. Just because it's 20%, it means that we move, that there's most of the time we're going to move this patient towards one side, but there's 20% of the time it's going to be on the other side. And that's why it's so important to be collaborating with doctors and showing this transparency as to, look, for this to be good for your patients or to be ethically correct, we're going to help you, but the last decision has to be yours. You have to understand if this patient is on the 80% side or on the 20% side. So it's a collaboration that makes the ethical thing work, not just us saying something or the doctor saying something. It's working together. And then that leads to what you were saying about data sets. I think we have to understand, especially when we're talking about Latin America, which is this forum, we can't rely 100% on, or not even 10% on all the international data sets. International data sets are made in history between United States and Europe, which has traditionally a very different population than ours. If you look at, for example, bone age, the Bible of bone age was created by U.S. physicians in a U.S. environment with mostly white, well-fed kids in areas where you have very good infrastructure, be it of sanitation and water and stuff like this. You can't compare this to other regions. If you look at Brazil or even or other areas where people develop differently, and it's not the same. So you have to understand the reality of our data set. Breast imaging is the same thing. Breast density in Brazil is going to be very different as it is in the United States or as it is in Asia because of the difference in our population. So you have to be very transparent as to where your data came from, because that's going to help you apply. And we use a lot of the data. Most of our data is from Brazil because we're treating in Brazilian hospitals. So we have to be able to understand that this is a difference. Obviously, a chest is a chest. Like a lung in Chile, a lung in Ethiopia, a lung in Brazil is similar, yes, but you have to contextualize. This is not the picture. People aren't pictures, right? They're movies. We're a movie that lasts 90, 100, 120 years.
Thank you so much. Thank you so much for that final point. Before we finish our panel, and before also giving to Patricia to summarize this discussion, I want to remind the audience to put your question and answer. This is the moment. And I would like to do a final question to both. And I'm going to relate to one of the comments that we have on the Q&A chat that is related with rural populations and poor and vulnerable populations, right? How and my question is about the trends, right? How do you see also the trends on AI in radiology for the future in the coming years? Never mind what is your next thing, right? But also how can we bring these technologies and benefit poor and vulnerable populations or rural populations or populations that are far away from the big medical centers? And taking into account, you know, the other challenges such as the lack of connectivity or infrastructure or lack of resources. How can we really make a big potential of these technologies and support these populations that are more vulnerable and have less access to these type of services? So, Anthony, if you want to start, and then Esteban.
Perfect. So I think this is a perfect question because especially if we look at Brazil, which is where we're mostly working from now, you have these very highly densely populated cities, but you have a lot of the population in rural areas with low access to to hospitals, much less highly complex hospitals. Mostly, if there's a radiology department in a hospital close to them, it's probably just an analog or a digitalized X-ray or maybe an ultrasound machine. They have to travel kilometers and kilometers to go to a CT scanner or a mammogram. So there's two ways, right? There's one way that we can yell and ask for the governments to change. It's like this. But that's going to take a long time. And as entrepreneurs, we like to try and take things into our own hands. So what we've done, and I think is one of the good ways of doing this, is trying to make sure your technology is applicable and easily used anywhere. We like to say that if AI isn't used by everyone, it's useless. You can't say, oh, this only works in a very specific $2 million machine that has to be connected to an amazing fiber optic channel link that only exists in one building in São Paulo. It's not. That's not why AI exists. AI has to help the masses. So what we've been doing is we've been training our models on CR exams, even during the pandemic, in pictures of analog exams. Obviously, you lose ability to make decision making, but most importantly, you have to be able to understand the reality. So we can't have limitations for only very specific machines. We have to be trained for all kinds of machines, 20-year-old machines that we exist in Brazil. We have to be able to analyze this. The internet is iffy in certain regions of Brazil. True. So how do we make our algorithms, and this has been one of our big missions, not depend on very expensive GPUs that are only available in cloud in areas? Our algorithms are able to do predictions with very, very simple machines, sometimes even laptops that exist somewhere. So that's how we can do. We're able to lower the technical demands of our algorithms and the need for data transfer. This is what we can do. Obviously, there's a lot of things that the government that we can lobby and we can help, but those take time, and we want to be able to help today. So these are the things, the best ways for us to do this. And one of the reasons also why we went towards text, not just imaging, because when you're looking at text is quick, light, and easy to transfer. So if we're reading text from a very rural region and we're able to quickly tell them, look, your patient is a very high risk patient to being diabetic, hypertension, and having or some kind of disease, you're able to transfer that patient quickly to a high risk area. I'll move quickly to Esteban because I think they're calling his flight.
Yes, thank you, Anthony and Esteban. If you can also relay how the private sector could support the public sector, right, to reach those communities.
It's really. I like the analogy of translating our analog bodies to zeros and ones. And that's what we do. We are analog beings. So we are not deterministic, right? So we're not ones and zeros. And these are amazing machines. So being able to look inside of a living body through a CT, through an MR, through a PET scan, now is available on trucks. There are trucks equipped with these amazing machines, right? And there are, and it was mentioned, there are several different approaches to have this happen. So we are using technology. We can lower our expectation. We love to have the brightest, shiniest, newest machine, but we need to lower our expectations, our demands, the amount of memory and the capacity of our servers to be able to use them on low income or low settings, right? The private sector can help the public health sector in this collaboration, both generating new evidence, testing the newest and most advanced machines, and also helping in the process of teleradiology and testing and providing data sets. So for the proper training of the algorithms. I think that the future is really bright. There are so many things that we can do. Radiology, as I mentioned, is one of the most advanced and most mature technology industries inside of a hospital. Okay, so it's a fertile ground to start doing things from top to bottom, from beginning to the end. So yeah, I'm really thrilled to see what is going to happen in the following years. I think that there's a proper answer to lower income populations, rural populations, so less privileged patients and all. So it's really interesting.
Thank you so much, Esteban. Thank you so much, Anthony. Really, I would like to thank you both for providing such important insights about the role of AI in radiology within our region. And as one of the people in the Q&A said, your human approach is wonderful. It's amazing how you put the user or the patient or the person actually in the center, and how these technologies should support both the patients, also the physicians, and work with the physician and not substitute. So I really would like to thank you again for your time during this panel. I think, Esteban, you will catch your flight on time, I hope. And at this time, I would like to invite Patricia Jara, Sector Lead Specialist from the Social Protection and Health Division at the IDB, to summarize our discussion and discuss some of the points made by our speakers. Thank you so much, Anthony and Esteban again. And Patricia, over to you.
Thank you, Gabriel. Good morning, everybody. It's a very exciting conversation. I'm going to switch to Spanish. Me gustaría resumir parte de los temas que se han conversado en esta oportunidad en torno a 6 tópicos. Hemos hablado de la promesa de valor de la inteligencia artificial en salud y nos hemos referido a la capacidad de la tecnología de mejorar cobertura y mejorar oportunidad. Agregaría un tercer atributo, tal como decía Pablo en su intervención inicial. Cuando se hace bien el uso correcto de tecnologías complejas, puede efectivamente mejorar la calidad del juicio clínico, por lo tanto aporta seguridad al proceso de la gestión de pacientes. Y el caso de la radiología me parece que resulta muy elocuente en cuanto a cómo se puede sumar capacidad con diagnósticos más precisos. Un segundo punto que me parece importante comentar, la tecnología como un colaborador activo de la gestión clínica. Hemos hablado largamente de la demanda por contar con mejores herramientas para la gestión clínica en un campo que es, por definición, muy complejo. Y nos preguntamos entonces cuál es la capacidad real de proveer nuevas soluciones para responder a estas demandas complejas en salud. Y Esteban lo resumía de forma magistral en 3 puntos importantes que quiero recuperar. Hablaba de eficiencia y de calidad, pero en 3 niveles, ¿no? La tecnología optimizando procesos clínicos, la tecnología sumando capacidad de procesamiento de grandes volúmenes de datos, pero también la tecnología como un recurso para compensar la falta de recurso humano adecuado para hacer interpretación de datos complejos. Anthony también lo reforzaba y decía, estas nuevas soluciones para lectura de imágenes nos llevaba a pensar en cómo se estructura y en qué se apoya el proceso de toma de decisión clínica. Y mencionaba un tema no menor, la liberación de tiempo para que el personal de salud que trata con pacientes se pueda dedicar principalmente a la interacción clínica con pacientes. Esto me lleva a un tercer tema que tiene que ver con la tecnología de imágenes como un facilitador del flujo clínico en contextos de alta demanda. Y Anthony nos invitaba a pensar esto desde el punto de vista de lo que ocurre en las salas de urgencia y en los box de atención. A veces dejamos pasar esto y es un tema extraordinariamente importante. El flujo de la atención de los pacientes es complejo. Y las interacciones para el levantamiento de un diagnóstico y determinar un nivel de riesgo clínico, priorizar y tratar, se puede valer muy nutritiva y positivamente del uso inteligente de tecnología, porque no solo puede tomar menos tiempo, sino también moderar el nivel de riesgo asociado al levantamiento de un diagnóstico cuando el nivel de precisión logrado en el triaje se beneficia de la evidencia. Y Esteban nos decía, se reduce tiempo en la generación de una respuesta clínica segura, basada en un diagnóstico certero, que en definitiva lo que hace es acortar la distancia entre el tiempo en que se levanta un diagnóstico y se prescribe un tratamiento. Hasta aquí hemos hablado de promesa de valor de la tecnología y sobre todo la tecnología compleja que identificamos con esta etiqueta de inteligencia artificial. Pero me llevo a un cuarto punto, que es la generación de condiciones para la adopción efectiva de estas tecnologías inteligentes. Ya lo decían nuestros panelistas, la práctica clínica está cambiando y va a seguir cambiando. Será un proceso continuo y progresivo. Y un diagnóstico asistido por inteligencia artificial debería ser capaz de levantar buenos diagnósticos, pero todavía es una promesa de valor y debe ser demostrada con evidencia. Mostrar los beneficios de la inteligencia artificial para esta práctica clínica, disminuir las resistencias que pueden venir del lado del recurso humano, entrenar capacidades y en definitiva generar confianza. Y nuestros panelistas también lo traían a propósito de nuestras propuestas en LAC de esta construcción de confianza basada en uso seguro de datos con estándares de privacidad relacionados con el respeto irrestricto a la protección de datos de los pacientes, pero todo esto debe ser empírico y demostrar que se puede hacer. Esto me lleva al quinto tema, que es las fronteras y posibilidades del uso compartido de datos. Nuestros panelistas se refirieron bastante a esto. El uso de tecnología y particularmente de la tecnología inteligente permite generar y procesar grandes volúmenes de datos. En particular, si queremos entrenar nueva inteligencia artificial, requerimos de ese gran volumen de datos. Sobre todo para fines particulares, es necesario accesar a esos datos y esto genera temor. La gran pregunta es si se puede mantener rigor en el principio de protección de la privacidad de los pacientes y al mismo tiempo utilizar esa información para generar conocimiento como bien público. Y me parece que nuestros panelistas nos traen buenas noticias. Sí, es posible, se debe hacer, pero debemos entender cómo se puede avanzar mejor en combinar adecuadamente estos estándares con un uso inteligente y efectivo de tecnología. Y por último, no menos importante me parece, la usabilidad de las soluciones tecnológicas. Y Anthony lo traía en su última reflexión. ¿Cuánta complejidad hay que ponerle a estas tecnologías de apoyo a la gestión en salud para evitar tener que sumar complejidad a la complejidad? Tiene que ser una inteligencia accesible, sí, y Esteban lo reafirmaba, y lo debe ser justamente para que se pueda utilizar y de buena manera, porque la facilidad de uso de la tecnología será lo que en definitiva determine que se utilice con seguridad, con adherencia en el proceso clínico y un uso consistente por parte del personal de salud. Muchas gracias nuevamente, Gabriel, por el espacio. Ha sido una discusión extraordinariamente interesante.
Thank you so much, Patricia, for the wonderful summary of today's discussion. And with this, we finish our webinar of today. I would like to thank again to all our distinct speakers, to our leaders for their opening remarks, and again to Patricia for your summary. It was wonderful. It was exactly all the points that we discussed, and I think it's a great way to close this event. We hope to see you in our next webinar of the series Transforming Health in Latin America and in the Caribbean through Innovation, jointly organized by the IDB Lab and IDB Invest. Our next topic will be focused on how innovation is helping to overcome the dual challenge of non-communicable diseases and mental health. So stay tuned through our different social media platforms. Thank you and have a wonderful day.